This is Dr. Jeff Gold, and I have the honor of serving as the Chancellor here at the University of Nebraska Medical Center and the University of Nebraska at Omaha. And it's my pleasure to talk to you today about the GCHS PRAM tool. PRAM, of course, standing for Pandemic Recovery Acceleration Model. What it is my hope to do in the next few minutes is to review the history of how the PRAM was developed, why it was developed, and to share some of the preliminary experiences we've had in applying it to some of the important public health decision-making across the state of Nebraska and beyond. Going back to the very beginning, the PRAM was developed not as a way of predicting the future or modeling the impact of the COVID-19 pandemic, as there are many other institutions across the country and around the world that have developed models that have evolved over time to do so. The PRAM is quite different. The PRAM looks at a moment in time, today, and then it compares it to a trajectory that has been developed over the last 14 days, or what we'll call is one pandemic viral cycle. It is the concept of the PRAM to give public health leaders, elected officials, healthcare professionals, and communities optics into where they are at any moment in time and to help in their decision making. Understanding that we're in various stages of recovery from this pandemic across the United States and around the world, but also have a good deal of concern over potentials for resurgence and the implications of any changes that may occur as a result of, quote, unlocking our society from its current state. One good way to think about the PRAM is to talk about Grand Prix racing. It's a model that many understand quite well. So let's look at the yellow car and the red car on this graphic. So if the goal of the drivers of both of these vehicles is to get into the pit stop and get their tires changed, their oil refreshed, or whatever else may happen in the pit stop, there are a number of things that are important. One, of course, is where are they? Are they in that part of the track that they can safely get off and get into the pit stop? Or are they not? Secondly, what is their velocity? How fast are they going? And finally, are they accelerating or decelerating? So when we look at the metrics that are commonly used to describe the impact of the COVID-19 pandemic across our communities, we look most commonly at the positional metrics, the number of cases, the percent positive tests, the number of ventilators or hospital beds that are in use. But we don't look as carefully at the velocity of change, and very rarely at the acceleration or deceleration of that change. And that's where the PRAM tool becomes effective. So if you think about this, not on a Grand Prix racetrack, but if you think about it on a graphical plot, if we knew where the prior position was, and we knew where the current position is, and we knew the time it took to get those between those 2 points, let's say for the number of cases of COVID-19 reported on a daily basis, you could calculate out the velocity of change, and you could also calculate out the average acceleration over that, or deceleration over that period of time. And so this comes back to almost a discussion of high school physics, where the displacement is how much change is there. The velocity is how fast are the metrics changing. And the acceleration, of course, is how fast is the change changing. And the idea being that if we could look back over a 14-day cycle, we could make some decisions on resources and the impact of tightening or loosening non-pharmacologic interventions based upon not only the magnitude of change, but the velocity of change and the acceleration or deceleration of that change. Now, that would be a one-dimensional case, but if we could take this into a three-dimensional situation and change the metrics on the axes, and instead of looking at x's, y's, and z's, let's look at the three first disease values. And these are the number of newly confirmed cases of COVID-19 on a given day, the percentage of positive tests, which of course represents not only the number of tests that are done, but of course those that are positive, and then the number of COVID-related deaths on a given day. These would be new confirmed COVID-related deaths. So if the axes were not X, Y, and Z, but were the number of new cases, the number of COVID-related deaths, and the percent positive tests, we could have a three-dimensional assessment of movement from which we could calculate out not only displacement, but we could calculate out velocity of change and acceleration or deceleration of change. And then similarly, we could look at three resource metrics, and there are many to choose from, but for the purposes of our discussion today, we chose the number of hospital beds that are occupied by COVID-positive patients on a given day. We chose the number of intensive care unit beds occupied by COVID-positive patients on a given unit day, and then the number of ventilators that are utilized, recognizing that the number of staffed hospital beds and the number of staffed ICU beds and the number of staffed and available ventilators plays into all of this and will vary from time to time, but the absolute number will reflect not only the displacement or the number of hospital beds, intensive care unit beds, and ventilators, but also allows us to calculate out the velocity and the acceleration of change. So let's start to talk specifically about the PRAM index methodology. So the way the PRAM works is pretty simple. It looks at the last 3 days. So in this particular example from April 2020, it looks at the average of, in this particular case, the 16th, 17th, and 18th of the month. And that is referred to as the M1. So that could be the number of new cases, it could be the number of hospital beds, etc. And then it simultaneously looks at what we refer to as M2, which in this case would be April 5th through April 11th, or the prior 8 to 14 days. And these are rolling averages. So on the next day, for instance, the blue bar and the yellow bar would both move 1 day forward. And this was established to allow us to use the 3-day rolling average to try to blunt some of the impact of weekend access testing and reporting, as well as reporting of hospital statistics as well, in an attempt to smooth the curve. We didn't choose 5 days or 7 days for the most recent period because we wanted the changes to be as sensitive as possible to real time. And so for the illustration that I'm going to share with you today, this information is collected by the close of business every day and is compiled into these averages of rolling trends, velocities, and accelerations, and then is presented on a day-by-day basis for the previous day. What this does look at then is really the rolling trend for approximately a 14-day period, which theoretically would encompass the timeline from viral exposure through infection, symptom screening, testing, and reporting, and possibly even into early hospitalization. We know that hospitalization, placement into intensive care units, use of ventilators, and then tragically, in some instances, death, are lagging indicators. They occur later in the stages of disease, but are very important in understanding the impact of the viral pandemic. So if one were to chart this, and this is a chart from historic Nebraska data, what you see in the blue line, or M1, is actually the number of new COVID positive cases per day being reported into our state reporting systems for the averaged rolling trend for 1 to 3 days. And as you see, it is a bit choppy. And then below that, you see the M2 curve for this same 1 month period in yellow. And this reflects the prior 8 to 14 day numbers. So for the purposes of this particular sample of data, what you see is that the most recent 3 days has more new cases per day for this entire 30-day period than the lagging 8 to 14-day period. In working closely with our Department and College of Public Health, our public health officials in the state, and many across the nation, benchmarks were also established for the phase 1 aspects of the pandemic, which are referred to as the acceleration and plateau phase, for the deceleration stage, and then finally for the new baseline. All of the benchmarks I'm going to share with you today are benchmarks that were established for the acceleration and plateau phase, better known as phase 1. In the instance of new cases per day, that was established at 10 new cases per million per day. So you see the same chart, the same graphic representation of the 30-day interval sampled from Nebraska, but you also now see the dotted line representing the 10 new cases per million per day. This demonstrates that earlier in the month, for the first approximately 10 days, the state was under that 10 new cases per million per day, but then the 3-day rolling average and about 7 days later, the 8 to 14-day rolling average went over the benchmark number. If you were to take the ratio between the most recent 3 days and the 8 to 14-day period, it's possible to get a look at the velocity. So what you see in the lower left-hand corner is a graphic depiction of the 3-color chart that's used in all of our reporting structures. You see that in the green at the very bottom, there's actually a decrease in the velocity. That is to say, the ratio between the most recent 3 days and the 8 to 14-day period is a number less than 1. If that number is between 1 and 2, that is to say, it's between no change over this 14-day period and doubling, which is still significant, that would be referred to as a slow velocity increase. And then in the red portion of the graphic, what you see is the rapid velocity increase, which is on a scale between 2 and 10-fold. So at the very top of the red zone, the number of new cases per day, for instance, is 10 times higher than it was the week before, the previous 8 to 14-day period. So if you were to take that same graph of the number of new cases per day over the 30-day period in the state of Nebraska, in the lower right, what you would see what it looked like, again, with the 0 increase and 0 decrease being represented by the dotted line. In this instance, what you can see is that for the beginning of the month, the state was in the yellow zone, and then it went slightly into the red, and then peaked at a ratio of velocity of about 4, which meant that the number of new cases per day during that portion of the month were actually 4 times higher for the previous 3 days than they were for the 8 to 14-day period. And then over the rest of the month, the velocity and the acceleration slowly decreased to the point that we had a deceleration and we had a falling of the velocity, trends that we would all agree are positive, representing the control of the pandemic during this period of time. So shifting to this more robust graphic, you now see the disease impact of the region. And again, this information is garnered every 24 hours and is presented for the entire state for the 6 healthcare collaboratives across the state and for the 19 local public health districts of the state. So 3 different levels of granularity. In the left-hand panels, you see the prior 1 to 3 day rolling average. You see the 8 to 14 day average for this particular area, which I believe happens to be the Omaha Metro Healthcare Collaborative. And then below that, you see the red, yellow, and green depiction of that same period of time. So again, in the red, with velocities far above doubling, actually up to approximately 4, then falling down to about 1, and then rising back up to 4 at the end of the month. In the middle panels, you see the data from the percent positive tests per day, and in the far right, you see the panels from the number of deaths per day. So if we were to take the number of new cases, the number of new deaths, and the percent positive tests and average them, we calculate what's called the disease trend index. And similarly, we calculate the resource trend index, the RTI, from the average of the hospitalizations, intensive care unit stays, and ventilator utilizations over the same period of time. These equations indicate that cases, deaths, and tests could all be weighted differently, but for purposes of our discussion today, they're weighted equally. Now, some might say that deaths may be more important than cases, and cases may be more important than the percent positive tests, or the other way around. That could be determined based on the needs of a local municipality, a state, or even a small nation. Similarly, in the resource trends, the impacts of the use of ventilators, if they are more scarce, could be weighted more heavily than routine acute care hospital admissions. But again, for the purposes of our discussion today, they're all weighted as one. Assuming that they're all weighted as one, then we do two things with them. First, we calculate for every geographic distribution once a day the Recovery Combined Index, or the RCI. And the RCI is similarly calculated as the non-weighted average between the disease trend index and the resource trend index. The RRI, the Recovery Ratio Index, is just that. It's the ratio between the resource trend index and the disease index. And so, for instance, if that were at a 1-to-1 ratio, what that would tell us is that the velocity and acceleration of change between the use of hospital resources, staffed hospital beds, ventilators, and intensive care, and the velocity and acceleration of change of new cases, percent positive tests, and deaths were both changing at the same rate. If this were in the red, we'd be burning through more resources than the rate of expansion of the disease. If this were in the green, the disease would be increasing faster than the resources were being utilized. Again, recognizing that hospitalization is a lagging indicator. So let's go back to our Grand Prix racetrack for a minute, and let's look at the yellow and the red car, affectionately known as Car 1 and Car 2. So for Car 1, you see that particular car is in the outer lane, is proceeding at 50 miles per hour, and is decelerating at the rate of negative 50 miles per hour per minute. And so what you would assume from that is that the location is good, the position, the velocity is reasonable, and the acceleration or deceleration is reasonable, and therefore a decision to exit the track and get the tires changed would probably be a safe decision. Not being a Grand Prix race car driver, far be it from me to weigh in on that, but that would be a good assumption, I think. Now, if I were the driver in the red car, car number 2, I'm on the inner side of the track, so I'd have to cross over to another lane to get off. Now, I guess that could be done, but not without some risk. But I'm also cruising along at 100 miles an hour and accelerating at 50 miles per hour per minute. And so one could say that the position is at least in the yellow, if not in the red, that the velocity is solidly too fast to safely get off the track, and that the acceleration is too high to get off the track. So one could create a dashboard to look at these parameters. In a very similar way, one can look at the 3 disease indices and the 3 resource indices. First, you can look at the absolute number on a given day, and this is Nebraska data again from a while back. So for instance, at the 10 cases per million benchmark, with 1.93 million people in the state, at that particular day, we were well over the benchmark. So these are the position numbers. They're not the velocity or the acceleration. Similarly, for tests, confirmed deaths, hospital beds, ICU beds, and ventilator use compared to the benchmarks established for the state. When you look at the lower four, you look at the disease trend index and the resource trend index. So those are the velocities of change. So remember we said anything below 2 would be yellow, anything below 1 would be green, and anything above 2 would be red. And so you see all of those were in the green zone on that particular day. Then you can very easily add the velocity and the acceleration data to this chart. So it's not only telling you as to where the new cases per day is, but it tells you how fast they are changing, and then it tells you also what the acceleration or deceleration is. So on this particular chart, what you can see is the velocity of change is positive in all of these numbers, but the acceleration is actually a negative number. So just to give you a little bit more detail then, the state of Nebraska, as we said earlier, is broken into 6 geographic healthcare collaborative districts. It's possible, therefore, to not only aggregate all of the data for the state into this red, yellow, and green format dashboard, but also to look at each of the 6 healthcare collaboratives, as well as even separately at the 19 local public health districts. So this would be in rough geographic version of the 6 dashboards for a given day. In the upper right corner, you're seeing the northeastern part of the state. In the lower left corner, you're seeing the southwestern part of the state equivalently. And I think one of the most important conclusions from looking at this is that they're all different. Not only is the color difference, but the rates of acceleration and deceleration and the velocities of change are significantly different in these 6 geographic areas of the state, which are determined largely by referral bases and networking of hospitals, clinics, ambulatory care, testing laboratories, and other such important features. So let's just take a minute and let's look at the Nebraska data for the state. Here you see the benchmarks. We talked a little bit about the 10 new cases per million, the 5% positive tests, and the 0.25 deaths per day per million. The benchmarks that were established for resources are a 15% utilization of all acute care staffed hospital beds, a 20% utilization of all intensive care staffed hospital beds, and 25% utilization of all regional staffed ventilator. Now these are arbitrary, these are all arbitrary, but they're all based on a logical utilization ratio. Now some might question as to why it's not the empty beds that are being tracked as opposed to the utilized beds, but the simple answer would be that as we continue to recover from the pandemic, as we bring more elective procedures back to our hospitals, as some of the latent and delayed care for joint replacement and cardiac procedures and others become more common, they are going to occupy acute care beds, intensive care beds, and of course ventilators over a period of time. And so we don't want to create the confusion of the percentage of ventilators that are being unused at any given time, rather than we're more interested in the absolute utilization due to COVID. And so again, as you saw earlier, this is the benchmark on this particular day, the dashboard as we call it, which shows both the metric benchmarks, velocity benchmarks, and the acceleration benchmarks, and it gives us a picture of where the state is on a given day. This would be the 6 healthcare collaborative regions. And now we get into some of the graphs and charts here, and what you see on the far left 2 panels would be the 3-day rolling average and the 8 to 14-day rolling average, and the velocity plot below that. In the middle, you're looking at the percentage of new cases, again in blue for the last 3 days, in yellow for the 3-day rolling, rolling average from days 8 to 14, and below it the ratio or the velocity. And then finally in the far right 2 panels, in blue you're looking at the number of COVID positive confirmed deaths per day. And in yellow, you're looking at the 8 to 14 day rolling average. The dotted lines in the top panels indicate the benchmarks for the entire state, and the three below give you the green, yellow, and red zones of the velocity of change over this 14-day period. This is the same data presented in a cumulative way, and that's because a lot of our health departments and leadership across the state are not just interested in the daily rolling average, but are interested in the cumulative numbers of cases, of positive tests, and of course, of deaths. These panels now look at the resource utilization. Again, in the far left, you're looking at the number of staffed acute care hospital beds statewide for the last 3 days in blue, and for the 8 to 14 day period in yellow. In the middle panels, you're looking again at the number of acute care intensive care unit beds that are occupied by COVID positive patients during these same time periods. And in the far right, you're looking at the number of ventilators that are in use in the state, again, over the 3 day rolling average in blue, and over the 8 to 14 day period in yellow. The three panels below, of course, look at the velocity of change, and you see that there is a pattern to each of these. Interestingly, the intensive care unit numbers and the ventilator numbers are not identical, but they're very similar, indicating that there's a slightly higher velocity of change for the use of ventilators and intensive care units, and that has to do with the fact that there are many more intensive care unit beds in the state than there are of ventilators, and there are many patients that occupy those beds that are not COVID positive, that are not on a ventilator. Finally, these 6 panels sum it all up over a running period of time, and it's the last day, the numbers from each of the last days that goes into the red, yellow, and green dashboard that we showed you a little bit earlier. In the upper left, you're looking at the DTI, or the disease trend index, so that's cases, percent positive tests, and deaths rolled into one. Below that, you're looking at the resource trend index, and again, that would be acute care hospital beds, intensive care hospital beds, and ventilators. In the top middle, you're looking at the composite of all of the numbers, which represent the recovery composite index. So that is the disease and the resource trend indices averaged in an equal weight. So you see a composite of that. So for instance, most recently it looks like that index was right at the interface between yellow and green, which would be a 1.0 velocity change. Below that, you see the ratio. So you see the ratio between the resource trend index and the disease trend index. So again, just briefly verbally describing this, it was fairly low in the yellow to green zone for a reasonable period of time, and then it started to get into the red. And as it started to get into the red, that's an indicator that the velocity of change of the use of healthcare resources was exceeding the rate of spread and impact of the disease. And so we've been able to do this now for the entire state for almost 2 months, and it has given us information regarding resource planning and, of course, evaluation of decision making for the use of tightening or changing any of the non-pharmacologic physical distancing reopening interventions. I hope that this was helpful. If there are any questions, concerns, comments, or suggestions, we're more than pleased to provide background and references, and of course source data if it is of interest. And indeed, please feel free to reach out and ask at any time.